Hello everyone, and happy Thursday, or whatever day it is. Regardless, I hope you are in some comfy pants and you are able to enjoy me and Selene's presentation about working in outpatient settings. So why are outpatient settings important, you ask? A survey was conducted in 2017 to 2020, and the results show that there has been a statistically significant decrease in mental health stigma over the years. So as a result, more and more of society has warmed up to the idea of counseling or getting help for their mental illnesses. And recently, it was reported that 42% of American adults have reported seeing a counselor sometime in their life. So it's important to take the perspective of someone without a lot of knowledge about the mental health field when discussing why outpatient therapy is really important nowadays. The terms therapy and counseling are often used by individuals in society referring to what we call outpatient counseling. It's the really classic person walks into an office and sits on a large couch stereotype image of what mental health services entail. So it's important for us to discuss outpatient counseling due to this, but it's also really important for us to have a good knowledge of what outpatient counseling is, partially due to this program's specialized modality in cognitive behavioral therapy. CBT is structured in a way that works best for outpatient structures. However, despite the chosen modality of each clinician, outpatient therapy is important to understand and practice because it treats a really large range of people. And it's largely the most accessible to clients, and it treats the lowest severity of mental illnesses, which makes it extremely versatile and applicable. So what is outpatient counseling and what's it for? Outpatient counseling is different than inpatient counseling because you're working out of an office. This means that the client comes to you. The clinician stays put and the client comes into an office rather than the clinician going into a residential space where the client may be permanently or temporarily residing. Outpatient counseling is distinct from other types of counseling because, as I previously said, it treats the lowest severity. So there is no immediate threat to safety of the client, so there's a lack of need to be monitored overnight. So this allows the client come freely between session and outside life. So outpatient therapy largely serves a variety of functions. The first is to provide education to aid in daily functioning within the context of mental health issues. So this basically means providing information to regular old people about mental health and insight into their own patterns so they can have a positive influence on their functioning in day-to-day life. So this might entail raising awareness of maladaptive patterns and relating that to a specific diagnosis or a specific set of goals that they want to work on. And that really stays in the present, or depending on the modality, you can tap into the individual's past experiences, a lot of storytelling, narrative experiences, and how that contributes to past and present functioning. So next, we will talk about the types of outpatient settings that there are. So largely, clinics and centers may range from being established agencies to other more informal settings like churches or shelters that provide safe spaces for populations to consult with professionals during specified hours. Community mental health centers may be nonprofit or for-profit agencies, although they are usually nonprofit. Outpatient counseling may also occur out of hospitals, private practices, like a private practice office. A counselor may conduct outpatient therapy out of their own home or via telehealth nowadays. It may be in more specialized places as well, such as substance abuse treatment centers, K-12 schools, colleges or universities, or even correctional facilities. And this one I had to think about for a little while because it's interesting about correctional facilities. You would think that it may be designated as an inpatient facility because the clients will reside in the correctional facility, but due to the nature of the facility, it is technically considered outpatient when a clinician goes into the facility and is not directly involved in day-to-day care of the client. They will be set up in an office with a specified caseload that will then come to the office within the correctional facility, thus it being outpatient. So next we're going to talk about the different ways you can work in outpatient counseling. So these are largely part-time, full-time, or fee-for-service positions. So if you're working in a part-time outpatient setting, you're probably working less than 35 hours per week. And I know a lot of us understand this because this is what we're doing for our internship. So you have a lot of flexibility within your schedule. Some people only work in after-school programs or on weekends when clients may be more available. It can range from 5 hours a week to 20 hours a week. Really depends on the setting that you're working in and your access to clients. Meanwhile, full-time clinicians may be working up to 35 or 40 hours a week, if not more. And they usually hold the same flexibility in making schedules. So these hours per week may not necessarily be a classic 9 to 5, Monday through Friday. Clinicians may see clients earlier in the morning or oftentimes when seeing the younger populations later into the evening, depending on schedules and availability of clients. So full-time and part-time positions can be either salaried or an hourly pay. What differs this from fee-for-service is that fee-for-service clinicians will only get paid for billable hours. So what this means is that a fee-for-service clinician will only get paid by the insurance company or the agency for the hour or half hour that they saw a client. This differs from positions like in-home therapy or residential settings because you are not paid for the paperwork or the day-to-day functions around the job. It's only for what is able to be billed towards insurance. So occasionally, if you're working for an agency with strict productivity, if you do not meet productivity in a fee-for-service job, you may be risking your benefits because they may depend on billing a specific quota of billable hours per week. So next we're going to talk about IOP, and IOP stands for Intensive Outpatient. So IOP differs from regular outpatient because it involves 3 to 4 hours of treatment for up to 5 days a week at a specific outpatient setting. So IOPs are designed to provide more structure and support than standard outpatient programs, while still allowing its patients the time and flexibility to tend to outside responsibilities. The length of an IOP may be anywhere from weeks to a year, but typically 90 days is the minimum recommendation for an intensive outpatient service. And a lot of the times, IOPs can occur in a variety of settings. So pretty traditionally, they occur in hospitals with access to psychiatry, as well as settings for individual or group sessions. But they can also happen in other settings like community health agencies. IOPs generally provide a great middle sector between regular outpatient counseling and a higher level of care like a PHP or an IHT service. So what do outpatient sessions look like? So typically each session is approximately 45 to 50 minutes. However, this can differ depending on the population that you're seeing. It can decrease if you are working with a child with ADHD who cannot sit still, or it can increase if you have permission from an insurance company to do specific trauma work or other intensive services. And the length of overall treatment will largely differ from client to client and by modality to modality. CBT, for example, usually aims to have its clients in and out of treatment within a few months, while many psychodynamic approaches may take years to feel comfortable discharging. So I'm going to go through about what a typical session will look like, beginning, middle, and end, and the beginning, middle, and end of overall treatment in an outpatient setting. But before I start to do this, I want to make a point especially in the session-by-session overview, that this will largely vary depending on the clinician's style or modality that they follow. But generally, the beginning of a session will involve agenda setting or an emotional check-in to determine the client's immediate needs in that moment. Because in outpatient settings, we don't have access to clients 24/7 or even more than an hour, the beginning of a session will probably take stock of the client's immediate needs and then go from there. So the beginning of the session will also include assessment from time to time to track clients' progress or assess for new problems. The middle of a session is largely where that discussion and exploration comes in. This is when outpatient clinicians input interventions and promote insight with their clients to make progress. And then the end of sessions will involve a summary of progress or content that the session went over, as well as planning for the future. Planning for the future may be within the context of therapy, which connects to the progress of overall treatment, or it may also be planning for continued education within the context of the intervention that was used, such as planning homework assignments to be completed in between sessions. So while each session has a beginning, middle, and end, the overall treatment within an outpatient setting also has a structured beginning, middle, and end. So what this may look like is that in the beginning sessions, these may be focused on rapport building between the client and the clinician, establishing an agreed upon diagnosis or a set of goals that will be contributing to overall treatment planning, and a clear understanding of what therapy is and clarifying expectations for overall treatment. The middle sessions, no matter the modality, should be exploring patterns of being, whether that be thoughts, emotions, behaviors, or memories, experiences, somatic symptoms, etc., and then looking for ways to interrupt patterns and promote healthier living. And then the ending part of treatment should be preparing for obstacles or anticipating problems which would interfere with the progress that was already being made, and preparing for termination or not having an individual to talk to and living on their own without coming to session once a week or however often. Outpatient therapy is also special in that way because it can be twice a week, once a week, bi-weekly, or even monthly, depending on the needs of the client. So there's a lot of freedom in the structure and the content of outpatient therapy to meet the client in terms of their needs and their strengths and their preferences.
So now we're going to be talking about the duties outside of sessions. The first one I have here is paperwork, but I will discuss that more in depth on the next slide you'll see. The second one I have is case management, and this includes collateral contacts and assisting with other outside services and resources. So what and how much you do will depend on the agency. Some clients may require more time meeting with other providers and being connected with more services. Case management basically stands for the overall maintenance of the client's psychological, physical, and social environment, and setting goals to, reduce their distress, fostering their personal growth and survival, and possibly getting them involved in the community. Case management can also include a wide variety of services, helping with medical care, employment and unemployment services, school services, disability, social services, finding food pantries and domestic violence shelters, housing, transportation, so much more. Next here I have is professional advocacy. So outside of sessions, we can support various policies and standards for our profession. Another way to do this, Dr. V mentioned in his book, would be joining our state's mental health counseling association. And the American Counseling Association website actually has more resources for more information about this. Next I have here is outreach. In other words, connecting with the community. We can really use this to lower the stigma around mental health. We can share services, groups, resources with schools and other centers in the community. And we can also offer the agency as a possible place for them to meet their needs. We can also conduct survey assessments in the community to see the community's needs. And we can host topics and presentation at community centers to help inform and destigmatize certain disorders that we find may be more present in their community. Next, I have colleagues, and we're interacting with these individuals on site every day in outpatient settings. This could include counselors or even other providers to collaborate, and this can be a positive or negative experience, but more positively, we can understand different perspectives and approaches to care while talking with them. When we're thinking of colleagues off-site and outside of the agency, this would include outside providers, so other, school administrators, social workers, PCP, psychiatrists, if they're not already working inside your agency. Next, I have supervision. This is another duty outside of sessions in outpatient settings. So we have individual and group supervision at sites. Individual supervision is ideally with a colleague who has more experience and is licensed. We meet with them about 1 to 2 hours a week. They really are nurturing our development as therapists, helping us understand the basic day-to-day activities, focusing on skills that are specific to our theoretical orientation. Some of this supervision should include reviewing audio, video, or live observation for feedback. Some supervisors may have you observe them. And of course, we report. These are our first point of contacts to report to them for any agency concerns or a client crisis. We also have group supervision, which may involve the same or a different supervisor in the agency, and that's held with other colleagues. These meeting also 1 to 2 hours a week. We could do case consultations, get advice from our colleagues. If we're stuck, getting their feedback can be also very helpful. Finally here, I have team meetings, trainings, working towards getting CEUs, and other expectations depending on the agency. Some agencies, meet every other week for a team meeting to go over any agency changes. Salary changes, things that are going on within the agency. They also might explain any trainings that they're offering, which most likely can be eligible for CEUs. Team meetings can also include other community centers or resources coming into the agency and giving a presentation to help everyone in the agency be more knowledgeable of the services that are offered within the community, so we can be more knowledgeable and point our clients in that direction. So, like I said before, the next slide is talking about insurance, billing, paperwork. So I'm going to start off with managed care organizations, which are MCOs. And these organizations provide third-party reimbursement for services. Their overarching goal is to reduce the cost of therapy and increase the quality of care. Most agencies will have relationships with managed care organizations, and the contact that we make individually as therapists will vary by agency, but just having a general understanding of them is pretty important. We need our SMART goals and treatment plans, progress notes, in other words, proof that the sessions happened and that it matches our treatment goals and interventions in order to be reimbursed. Moving on to pre-authorization and authorization, these are needed in order to be reimbursed for sessions as well. Pre-authorization requires an outpatient treatment report, an OTR, which provides information about clients presenting problems, their presentation, and their need for treatment. It's essentially viewed as the initial treatment plan. We gather this information in intake and kind of support this is why diagnosis is required by the end of intake. The next one I have here is outpatient reports and paperwork, our favorite thing. And these, like I said before, are required for billing reimbursements. So starting off with intake assessments, they take about a week to complete, and we must report a formal diagnosis as required by the MCOs. Therefore, these assessments must be efficient and detailed. We collect historical information, indicators of current functioning, and the perspective of what they might want out of therapy. Other formal assessments can also be used here, and this will inform our case formulation and treatment plan, of course. So that brings us to our next one. Case formulations and treatment plans take about 2 to 3 weeks to complete with revisions. These should be done sooner rather than later, as it is the driving force of our sessions. Like I said earlier, we're using our SMART goals, and we should be collaborating with the clients and getting their feedback about these. Agencies typically require revisions quarterly or monthly, but they can revise over time as new things arise, and we're, continuously formulating our case. As we know, the treatment plan needs to follow the formulation, and it includes potential barriers, strengths, and recommendations for any additional services our client might need. The progress notes are next. They should be completed after every session to be reimbursed by MCOs, and this can include collateral notes or other case management notes that need to be documented. The next one is discharge plans and summaries. These are, including our remaining goals, our client's progress, the reason to terminate, possible future recommendations, the client's prognosis, their level of functioning, any possible referrals. And all of this information is good for the client's future experiences with therapy. Ideally, discharge will occur when therapy was successful and they're ready to terminate. Other times, this isn't the case. The client may have met their predetermined number of services that are offered by their MCO. Some clients may decide that they no longer want services, or it's no longer helpful, or just stop showing up. Or they were referred to another provider to continue their care. And termination can be planned months in ahead, or can be very abrupt. So that is that. So next I'm going to talk about some therapist and client obstacles that might be faced in outpatient therapy. First, starting off with struggles with billing and insurance. This can mean barriers taking on clients depending on their insurance if we are not licensed yet, and also struggles with communicating with insurance, getting authorizations if needed. Next, I have struggles with continuity of care, meaning we might have a difficult time following up with clients after discharge or finding time to participate in transfers recording documents or other things outside of sessions. Deadlines with heavy caseloads may also be difficult in that area. Next, we have family involvement, which is required when we're working with kids. Otherwise, we might struggle to make sustainable change. We might have fewer resources or options within the agency, thus requiring referrals and reaching out to other services. Large caseloads can also be an obstacle for doing full-time at 30 to 35 clients. This can lead to burnout, stress, and feeling overworked a lot quicker. Some agencies may also have specific theoretical and treatment approaches that they use in their agency, which may lessen the options of where we want to work if our approach doesn't align with them. Agencies may also have different requirements regarding how they do their paperwork and which documents they use, which can take some getting used to if we're switching agencies. Paperwork in general can also be a challenge to complete if we have a large caseload and get behind. Some agencies require a specific timeline, but in general, we shouldn't go longer than 24 hours because then we run the risk of forgetting what even happened in the session. Moving on to some client obstacles, the big one being time in between sessions. This time is crucial and it can really dictate how effective outpatient therapy can be. Clients might not practice their skills or integrate what is being learned outside of sessions. There may be limited support or supervision outside of sessions, especially if they're in an unstable environment. So there's an increased chance to be inconsistent with the skills that they're learning in session and using them, applying them outside of sessions. There also may be limited opportunities for groups in outpatient settings. It's likely that only some agencies have certain groups, and they're probably more likely to be held in partial or inpatient treatment centers. Finally, transportation for a session that's being held for less than an hour can also be a barrier to attending therapy. More on the client side, not only is, engaging in therapy a commitment, but also driving to and from the office is a commitment. So that may cause some issues as well. So finally, we're going to talk about some therapist and client benefits in outpatient settings. Starting off with the therapist, the big one being we might have some agency over our schedules, meaning that we're more likely to be able to decide when to schedule clients in our days and offer our availability that works for us. We may also have less intensive cases compared to inpatient cases. We might have some more flexibility. Now with telehealth and in person, we have more options to see clients, especially, if there are issues getting to the office, Zoom or telehealth can be a good backup option. Next, I have a more positive outlook, meaning that there are possibilities to have clients who can be better and discharged in a matter of months. So that's a big, benefit that can help with burnout. Next, I have positive work-life balance, which goes along with flexibility. Outpatient therapy is not as highly structured as inpatient therapy. So it's easy to go, see your clients, go home, that kind of thing. Next, I have a large client population. We can see a very diverse, unique, and wide variety population of clients. Finally, we have coworkers who we can see as a benefit. They're in the office, they're there to support and help us as needed, offer their advice, their feedback, different interventions that they're using, different supports, using their resources, all of that good stuff. Finally, looking at client benefits, the client isn't being separated from their natural supports, meaning that they can still attend school, work, etc. They go to their session, they go back to work. Some Individuals even have it as their self-care lunch break, as Dr. V has mentioned before. So it's pretty flexible too for the client. Another benefit is that it is a lot less expensive than PHP or higher levels of care. There also may be more options to choose from. A lot of agencies offer outpatient as their primary form of treatment, as opposed to inpatient having a select few locations. These sessions are also often covered by insurance. The outpatient therapy also gives clients the opportunity to practice their skills and eventually learn how to be their own therapist, which is huge. And it's also easier to hold family sessions with kids in outpatient settings, or have quick family conversations with family members, pull them into sessions if needed when they're waiting in the waiting room, or have a quick, little wrap up or homework assignment that you give them in the waiting room to work on till you see them next. So I'll list off our first two discussion questions. So the first one is, can you think of any other obstacles of outpatient therapy for either therapists or clients? And the second one is, can you think of any other benefits of outpatient therapy for either therapists or clients?
And our last discussion question is, how do you think therapist-client boundaries differ in outpatient settings versus inpatient settings? Thanks, guys, so much for listening. Have a great week.